Very much. Good morning, everybody. In the next coming minutes, I would like to introduce you the progress of my PhD thesis with the title Neurocognitive Changes After Different Brain Tumor Treatments in Children. My name is Renáta Kiss-Miki. I'm a second-year PhD student and also a medical doctor at National Institute of Mental Health, Neurology and Neurosurgery. And my vision is to give a better life with less side effects for pediatric brain tumor survivors. And for this, my vision is to help the pediatric brain cancer patients and the researchers to improve the quality of life of them. For this, I'm running two projects, in both of them investigating different types of brain tumors and measuring different outcomes, such as the neurocognitive decline. In my first project, by performing a systematic review and meta-analysis, I was comparing the two major types of radiotherapy, the proton and the photon one. Why it is important? As we know, childhood brain cancer is a huge challenge in pediatric oncology. It's the second most common tumor types among pediatric population, and it has a high impact to the quality of life. Based on the American Cancer Society, annually 4,000 new diagnoses are numbered, and more than 80% of them require irradiation to provide optimal survival. As every therapy, the radiotherapy has also side effects, and these side effects can be life-threatening, such as the neurological problem, endocrine deficits, or the neurocognitive decline. So our aim was to find the least harmful but yet effective radiotherapy modality for pediatric brain cancer patients. Here you can see the main differences between the photon and proton radiotherapy. The photon uses X-rays or gamma rays. The radiation affects both the tumor and the surrounding tissue, but it's commonly used, widely available, and suitable for various types of tumors. On the other hand, the proton uses charged particles. It has a precise targeting to the tumor and sparing the healthy tissue, but it has a limited availability, may require some specialized facilities, but it's beneficial for tumors near critical structures and for young patients. So the clinical question was, which irradiation method is the least harmful but still effective for children treated with brain tumors? We enrolled children with brain tumors, compared the two major types of radiotherapy, the proton and the photon one, and we measured outcomes such as the survival or frequency and severity of side effects. The hypothesis was that radiotherapy methods that uses photon beams improves the survival and decreases the number of adverse impacts compared to the other types. After a thorough analysis of the literature, we gathered 29 articles eligible for data extraction. Here you can see the list of the outcomes that we could extract from the articles. As outcome measure, we use the odds ratio with 95% of confidence interval and the mean differences. And in the next coming slides, I would like to show you some of our main findings. For example, the 5-year overall survival. This was a very commonly reported outcome, and all of the included studies are retrospective cohort studies with a homogeneous population. And in this case, the odds ratio was equal with 0.80, which shows us that by using the photon radiotherapy, there is a tendency to increase the 5-year overall survival, because if odds ratio is equal with 1, it means that there is no difference between the two radiotherapy modalities. If it's lower than 1, it means that preferring photon can reduce the adverse effect, and below 1, it means that the photon radiotherapy can be beneficial. So this result was statistically not significant result, but clinically it is very significant. Hypothyroidism, one of the most frequently reported side effects from the endocrine group, can be seen in this plot. Here we used as well odds ratio, and all of the included studies are retrospective cohort studies with a homogeneous population, and the odds ratio equal with 0.17 shows us that there is a 6 times higher chance to develop hypothyroidism by using photon radiotherapy than by using proton radiotherapy, and this was also a statistically significant result. The IQ level from the neurocognitive decline group can be seen on this forest plot. Here we use the mean difference as a measure of effect, and it's equal with 11.91, which shows us that by using the proton radiotherapy, we can gather higher points or different scales than by using the photon radiotherapy. And yes, we have in this case a heterogeneous population, but this was a statistically significant result. Here you can see a table about the outcomes that we could measure. All the highlighted outcomes with red are a statistically significant result as well. But if we are checking the odds ratios, we can say that by using the proton radiotherapy, we can reduce a lot of outcomes and we can increase the quality of life of children with brain tumors. So the strength of our study is that only comparative studies are included with a high number of outcomes. Many tumors were investigated and a high number of population. But as limitation, we have to highlight the missing data due to data collection, different follow-up periods and follow-up protocols, and also the presence of moderate and high risk of bias. So in conclusion, we can say that proton is better to reducing the toxicity of this treatment method, but regarding overall survival, there is just a slight tendency that it can increase the 5-year overall survival. As an implication for practice, longer follow-up for proton therapy and more proton centers are needed, and then as implication for research, more two-arm comparisons and more studies to investigate the side effects based on the CTCA scale are needed. And we submitted our manuscript yesterday to the Radiotherapy and Oncology Journal, and now it's under review. In my second project, I would like to adapt a cerebellar Mutis scale in Hungarian for children. This is a scale which is measuring the complication of posterior fossa tumor surgery. This Mutis appears after 24 hours from surgery in 1/3 of cases. It has a high rate in children with malignant histopathology, for example, medulloblastoma. And as a long-term consequences, we must to highlight the persistent dysarthria, residual phonological impairment, but with rehabilitation, it can be recovered in approximately 6 months. This was developed by an Italian working group. It grades the duration and severity of symptoms. It is a very sensitive instrument to identify even the mild presentation of mutism, and it is an accurate prognostic stratification for an optimal planning of clinical and rehabilitative intervention as well. Here you can see the main questionnaire, and we would like to validate this by using this guideline for developing, translating, and validating questionnaires. The plan is to enroll 30 patients and to test them before the surgery, after the surgery, 1 day after the surgery, and the third test will be on the discharge day. We would like to include only children admitted to the National Institute of Mental Health, neurology and neurosurgery department, and with a diagnosis of posterior fossa tumor with brain MRI and eligible, of course, for surgical resection. So now we are on the plan of statistical approach, and we would like to use this questionnaire from February on our department. So in overview, I would like to finish both of my projects by the end of this year, and I would like to thank you for your attention with a quote from Ervin Lázár: "Even the most impossible things have to be tackled sometimes, because the most wonderful human experiences come from them." And thank you for your attention.
I would like to know if the mutism is the part of the posterior fossa syndrome.
Yes, in the past it was known as the posterior fossa syndrome, but nowadays they are separately, so the mutism is measured differently, and there are a lot of other outcomes such as neurocognitive decline as well, which are measured separately. So we cannot say, yes, in everyday use it is known as posterior fossa syndrome, but in science nowadays it is used separately.
I just want to ask, I'm not sure if I read it correctly, concerning the thrombocytopenia. It was not pretty sure for me, like if there is a significant difference and what is the outcome for this, based on the table. So if you can give me short talk, thank you.
So the question is there a difference between the proton and photon radiotherapy concerning thrombocytopenia?
Yes, because odds ratio for me it was not very clear. It was very quickly shown. So if you can tell me what's the result.
Yes, well, in case of thrombocytopenia, also the photon radiotherapy was better to reduce this type of adverse event. As in case of other ones as well. Only in case of neurological disorders and ophthalmological disorders perform better the photon radiotherapy than the proton one, based on our measures.
At the first project, in the conclusion regarding future clinical research, there's 2-arm comparisons are needed. Why? You answered the question that this proton type therapy is much better. Why you need... So it is contradictory. One side you recommend more proton machines and more proton treatment. Everybody must have proton treatment. And this is contradictory to say that more comparison are needed.
Yes, I would like to highlight this fact because of during the analysis we get some results which were clinically significant but statistically not. And I'm believing that by...
So sorry, what does it mean statistically not significant but clinically yes? So if somebody is statistically not significant, there is no difference.
Yes,
or
but
no?
I would not say so strictly like this, because during our analysis we can see numbers that can show us that proton is much more better, but by performing the different analysis tests they are not confirmed mathematically, but clinically they are relevant, I think so. And during our discussion with my supervisor and all the team, we were on the same page that yes, this is a clinically very significant result, although mathematically was not proven. And that's why I would like to...
Clinically very important,
yes,
if this at the level of evidence is proved,
yes,
but currently not.
Yes, and for this I would like to suggest this two-arm comparisons.
Sorry, but if this is statistically not proved, then you are not able to suggest that in everywhere this proton machine will be used, because this is not at the level of evidence is proved.
Well, to improve this kind of findings, I think I can suggest the improvement and to build much more articles based on this, because during the literature search I can find a lot of articles where only the proton was measured or only the photon was measured, and that's why I'm highlighting the importance of two-arm comparisons, because in this case we can pull data more correctly and we can make a more correct statistical analysis, like in our case, and as I highlighted, this was a bias and the limitation of my study.
Okay, I would be prone to continue this discussion, but unfortunately...
Thank you very much.